Hello friends, this is from Chambers and we will be talking about this second group of that Neisseria species, that is Neisseria gonorrhoeae. So let us share the screen. So guys, we have actually differentiated the two bacteria in the beginning, in the previous video. So here I would be only writing about this Neisseria gonorrhoeae, okay, or it is also known as gonococcus. It is also known as gonococcus. Okay. Now, what was the Neisseria meningitis? It was capsulated bacteria. It was capsulated bacteria, but this one is non-capsulated. This one is non-capsulated. Okay. That was gram negative. This is also gram negative. That was gram negative lens shaped. This should be what? Dash. This is gram negative dash shaped. Very nice answer. That is kidney shaped. Monococci or diplococci? Monococci or diplococci? Diplococci. See, you remember everything. Very genius people. Okay. Now, to understand what it is doing, first we need to understand what is the, how many strains it has, or how many things it can produce. So first thing I will start with is gonorrhea is basically, if you say, it is basically a human disease. Okay, it's a human disease and spreads by sexual transmission. Sexual transmission. Okay, sexual transmission. Now, if you talk about the males, if you talk about the males, you know already about the non-motile, non-sporing, non-capsulated, anaerobes, capnophilic, that kidney shaped and everything. Cat positive, oxidase positive, we have learned that. So this is cat positive, ox positive, isn't it? So they only ferment the glucose. We have learned that. Okay. Okay. Now, what are the virulence factors it has? First, I will tell you a virulence factor. Then we understand the disease. Virulence factors. What virulence factors it has? It has pili, or you can say febri. Okay. So what it is helping it to adhere, adhesion. It is helping in the adhesion of this, and will finally inhibit phagocytosis. It will inhibit phagocytosis. Okay. Now it also has outer membrane protein, like I talked in the last video. So OMP, it has, let me write two for you. It is porin 1. Okay. It is called protein first. And second is opacity associated protein, that is called protein 2. Okay. That is called protein 2. Easy. What is the function of these porin 1? It will help in the formation of pores, that is the membrane channels. It will help in the formation of pores, the membrane channels. Now we have strains on the basis of the genes. We have strains. Now we have various strains. So we type them. We do typing on the basis of what? Pore protein, isn't it? Pore protein. So if I want to classify them, I say pore protein is pore B1A, pore P1B. Now question will be asked in your exam. Out of two, who have the higher propensity, who have the higher, implications, I can say, for causing disseminated infection? Disseminated, spread, sort of a diffuse infection, disseminated everywhere. It is this. So remember that point. So this is responsible for, it has a tendency to cause what? Disseminated infection. Easy. Disseminated infection. Okay. Easy. Fine. Any doubt? Okay. So can I say POR1BA is responsible for DGI? Can I say DGI means disseminated gonococcal infections? Can I say POR1B is responsible for disseminated gonococcal infections. Sir, what is this doing, sir? आपने इसके बारे में नहीं बोला. You didn't told us about. POR 1B is responsible for adhesion. Sorry, not adhesion. It is responsible for local infection, local genital infection. Okay, local genital infection. It is responsible for this. Okay. Now it wants iron. It wants iron, or it wants some, metabolites. It wants some substrates to form some metabolites. So it should have a. Now, if I talk about iron, so to bind, to uptake, for the uptake of iron, should I have a protein? Yes, sir, I should have a protein. What should be the protein? Transferrin binding protein. Transferrin binding protein. It is having transferrin binding protein. So what comes in the virulence factor? He should have pili, he should have fimbri, or you can say OMP, which is of two types. It can be protein 1, protein 2, and protein 1 further classified on the basis of POR protein. Okay, protein 1 further, two serotypes. Okay, POR protein 1, please, protein 1 here. Now two serotypes. So POR 1B, POR B1A and POR B1B. POR B1A disseminated gonococcal infections. You should not only remember disseminator only. It can cause both. That is, local will also come. But here only POR 1B will be only implicated for local genital infections, isn't it? Easy. This opacity associated protein, what is it doing? It will be helping it to, it will be helping it to adhere and invade the organism. Okay, so adherence and invasion is by opacity associated protein, that is protein 2. Protein 1 will help in the formation of membrane channel pores. It has two major serotypes, POR B1A, POR B1B. POR B1A is responsible for local and disseminated gonococcal infections. POR 1B, POR B1B is responsible for local genital infections. That's easy. Second thing, it also has the same IgA protease. Can it go into the mucosa and degrade the mucosal IgA antibody? Can it go into the penis, the mucosal lining of genital tract of the male and female, and destroy the IgA natural protection? Will it destroy all the mucosal surfaces? Wherever you have the IgA antibody mucosal surfaces, it will destroy that. It has IgA1 protease. That's why it is causing urethritis. I will be telling you. Now it is having this loss. It is having that loss. What is the loss? Lipooligosaccharide. Lipooligosaccharide. Okay. Easy. If I tell you a question, what is the serotyping done on? Which protein? On the basis of which protein you do serotyping? You should write protein 1, or you said POR 1, PORin. Okay. If I tell you, what is, by the way, there is another typing, by the way, that is oxotyping. What is oxotyping? Oxotyping means when you are classifying them on the basis of nutritional requirements, the different strains which are using the food. So you classify those on the basis of food, if I talk about, what to talk about. If I talk about one strain is using arginine hypoxanthine uracil. One strain is using arginine hypoxanthine uracil for its growth. I will say it is AHU oxotype. Are we able to understand? If it was utilizing BDD, ABCD, if it was eating ABCD, I could say it is an ABCD oxotype. Are we able to understand? So will the nutritional requirements help me in classifying this bacteria on the on the typing of the gonococci? Yeah, so nutritional requirements is also helping me to identify. Okay. Yeah, I hope it is clear. Now we come to the interesting part of this disease, which we see in our daily life. I have some images for you. So if I take, this is the penis, the photo of a penis I have taken. This is a urethritis actually in the male. It's a male penis. So you can see the glands, and this is the cervix on the per vaginal examination. So we can now want to make it a bigger one. So can we see the, let me tell you first what it does. What can gonococcus cause? So it causes mostly venereal disease. I hope you understand what is venereal, okay? It is causing venereal diseases, okay? So let us talk today about the clinical manifestations of gonococcal infection. So see dears, what is happening? If I talk about the males, in males, it is causing acute urethritis. It is causing acute urethritis. What is urethritis? Inflammation of the urethra, male urethra. Okay. So what is happening if I take the photo of the male urethra? Now I have the, I have taken the, the superficially. So this is the opening of the urethra in the male, and this is the glands. Okay, penis. So can you see the mucopurulent discharge coming out? It is mucopurulent. Okay, don't consider it to be a sperm, because we have things to way to differentiate things. The patient will be coming to us with fever and all that. So by that thing we will be able to understand, yeah, he is having a gonococcal infection. Okay, so he will be having what? This is the purulent urethral discharge. Okay, that's the word. It is according to this, why I showed you this photograph, because gonococcus got the name of this. We said gonorrhea. So what is the meaning of gonorrhea? A flow of seed, something like a semen. Okay, this is semen. Semen also is the same, isn't it? So once the person gets the infection, so it takes 2 to 7 days for the, so incubation period is 2 to 7 days. Incubation period is 2 to 7 days. What are the complications of complications in male? What will happen? The complications, it will finally cause epididymitis. It will cause prostatitis. It causes penile edema, penis edema, edema of penis. It causes balanitis. Okay, causes balanitis. So this is the complications in male. Now tell me one thing. If I have this urethra, so if I can visualize in the brain, this is the urethra. So this urethra is connected to things. First, it will be, penile urethra, bulbar urethra, prostate urethra, and finally reach to prostate, for example. Will the tissues around the urethra also get infected, spread to the tissues around the urethra? Can I say periurethral tissues are involved? Periurethral tissues are involved. Can I say there will be abscess production? Can this abscess, while the bacteria is degrading everything, while the collagenases are being, they are working, acidity is being maintained there, so can I say it can lead to connection formation? It can form an abnormal connections with other tissues. Sinus, we call it sinus. So it can form sinuses. That is called as, please remember the name, water can perineum. Water can perineum. So once I have an infection and it is spreading to the periurethral tissues, that will lead to the formation of abscess. And that abscess can even spread and can make communication, abnormal communication between the tissues, isn't it? Like you are burying a tunnel, isn't it? You reach here, here, here. The infection is moving around the urethra. Urethra is here. This is the urethra. Urethra is here. You're retrogradively deleting everything in your way, isn't it? This is the periurethral tissue. This is the tissue around the urethra. So you are infecting and you are producing pus, and then finally you are forming a sinus. You are communicating. Things are now communicating. That we call the water can perineum. Water can perineum. Water can perineum. Easy. So in males, it's called the acute urethritis, epididymitis, prostatitis, edema of the penis, and balanitis. And incubation period is 2 to 7 days. Easy, so easy. This is the gonorrhea. Now, if I talk about the females, Females, it's less common. Females is less common. No, less, not common, less severe than the male. Okay, but females are carriers, asymptomatic carriers. Females are asymptomatic carriers. So this is the cervix. You can visualize if you have mostly third year people can understand. This is the cervix. Okay, this is the PV, per vaginal examination. So you can see this female is having a mucopurulent cervicitis. Can you see the mucopurulent? And we see the pus getting collected. Can you see? So this is mucopurulent. This is mucopurulent cervicitis. Cervicitis. This is mucopurulent cervicitis. Okay. So female will present to you with mucopurulent cervicitis. Okay. But if a girl comes to you, she's a girl and she has not achieved the puberty. She's a pre-pubertal girl. If she is a pre-pubertal girl, she will be coming to you with vulvovaginitis. Mostly, we are talking about the most common thing. So she will be coming to you with vulvovaginitis. Or if she is a post-menopausal woman, she will be coming to us with vulvovaginitis. But if an adult female is coming to me, because we know, in the adult, there is a Dodderline bacillus and everything, the stratified squamous epithelium is developed well in the adult vagina. So you may be knowing that from your gynecology or your anatomy. So if an adult female is coming to me, she is mostly resistant to gonococcal infection because in her vagina she is having the pH is low, the pH is acidic, and it will not be allowing the growth of the bacteria, and there will be some stratified squamous epithelium thickness is also very nice. So the adult vagina will not be coming with it. So vulvovaginitis you will be thinking in prepubertal females, girls, okay, and postmenopausal women. Okay. Now, if the female's fallopian tubes are involved, if her fallopian tubes get involved, we say the condition is called salpingitis. Her fallopian tubes are involved, we say salpingitis. And can it cause the pelvic inflammatory disease, PID, in females? Remember this word PID, pelvic inflammatory disease in the females, spreading and reaching. So can I say, if now tell me one thing, let us give you a logic. Now this is the fallopian tube, for example, and infection is here. Now it has destroyed the place. What will happen if inflammation is now resolving and scarring is happening? What will happen? This causes a stricture formation. What stricture? Now the place will get closed. Will the sperm travel to fertilize the egg in the isthmic ampullary junction? Can the sperm go? So will it lead to sterility? Will it lead to sterility? So she will be having the sterility. Okay. Easy. Have we understood the complication in female? Is it okay? So water can perineum will be happening in males. So remember that. Okay, water can perineum will be happening in males. Easy. Now look at me. What discharge were you able to understand? Now tell me, if discharge is happening, will it lead to painful, micturition, voiding? Will it lead to painful? Will it lead to painful, micturition? Salpingitis is the inflammation of fallopian tube. Okay, and if inflammation is happening, some things are getting destroyed. It is destroying the walls of the fallopian tube. For first year people, I am not going to detail about the process of inflammation. I'm just training myself. So you will be having this things will come together because regeneration and repair is happening, lead to stricture formation, scarring, and once if this is you have tubes. A fallopian tube is not now tube, it is going like this. It is having some stricture. So will the sperm be able to enter? No, sir. So it will lead to sterility. Okay. Easy. Now things are getting what? things are getting, the person is, when he passes the urine, will he have pain? So we will say he has dysuria. Dysuria. Okay. If they ask you what is the most common primary site of infection in the males, you should write urethra, prostate, epididymis, UPE. Males, UPE. Females, cervix, then urethra, then Bartholin glands. Female has Bartholin glands. Bartholinitis. Bartholinitis. This you will be teaching, learning very nicely in gynecology. I'll be teaching you in the gynecology part, okay? The gynecology video. So, urethritis, Bartholinitis. But what is the primary site where will the infection start? Cervix. In males, where will the infection start? Urethra. And prostate, then epididymis. So the second question will be asked, what is the most common presentation of gonococcal infection in male? Urethritis. What is the most common presentation? Please write on the copy. Urethritis. Others will be prostatitis, epididymitis. Okay. So he will be coming to you. The patient will be directly coming to you, the male. He will be coming with mucourethral discharge, purulent, and that will be dysuric. He will say, I have dysuria, painful voiding of urine. Okay. Female, primary site will be cervix. On PV vaginal examination, you will be appreciating cervix having the primary site of infection. Okay. Female, I said in the beginning, she will be asymptomatic. But she will be, what will they complain? She will be complaining of what? She will be complaining of some purulent vaginal discharge, dysuria, some urethral discharge. Okay. Now we are concerned that the infection may spread to uterus. If it spreads to uterus, then it will cause endometritis, isn't it? It will cause endometritis. If it is spreading to the then fallopian tubes, will lead to salpingitis. Will lead to salpingitis. Are we able to understand the case or not? Okay. So we are done with these two. These were the important, these two things. In females, there is a syndrome also caused by this gonococcal, that is Fitz-Hugh-Curtis syndrome. Fitz-Hugh-Curtis syndrome. Rarely seen. Fitz-Hugh-Curtis syndrome. What is the syndrome called? It is characterized by peritonitis. Peritoneum is the lining. It is called the peritonitis. Peritoneum is the lining of your abdominal cavity, isn't it? So peritonitis, and liver will be involved. That is called perihepatitis. Perihepatitis. So peritonitis and perihepatitis. Okay. Now they will be asking you what will be happening in the neonates. Neonate, a 20-day-old baby. So see this neonate, or see this. He is not actually. Yeah, can say. So can you appreciate in this neonate the purulent eye discharge? Can you see the purulent eye discharge? Can we see the purulent eye discharge? The purulent eye discharge. So the purulent eye discharge is actually called what? Ophthalmia neonatorum. Ophthalmia neonatorum. So in neonates, it causes what? Ophthalmia neonatorum. Ophthalmia neonatorum. What is ophthalmia neonatorum? Purulent eye discharge. Purulent eye discharge. But what is when will this happen? For example, baby was born 2 days ago. So on the second day or third day, he will be developing what? Or fifth day, he will be developing what? Ophthalmia neonatorum. How did this happen, sir? While his head, because the presentation, if the presentation was the head, for example, okay, if baby was coming from the head, a normal fetal presentation, okay, head presentation. So it got contaminated during passing through the maternal genital canal, through the birth canal. It got colonized. He got contaminated with the flora, because mother has a normal flora, isn't it? I told you. It is the normal genital flora of the mother. So it got contaminated and he got transmitted. I don't understand. So the infection got transmitted to during the birth. Okay, during the birth. What is the treatment for this? Microbiologically, not I'm not telling you the full treatment. It's microbiology treatment. We use what method? Creed's method. Remember this method. This is asked. Creed's method. What is the Creed's method? We instill. What is instill? We put the drops. So we instill silver nitrate, AgNO3, I should write in short, silver nitrate into the eyes. This is the Creed's method. Remember, just simple silver nitrate is given in the eyes. That is Creed's method. Okay. I hope you have understood these infections, the important infections, because you will be tackling these infections in your daily medical practice. That's why I showed you the diagrams also. Okay, in the first year only. Okay, so if I talk about the diagnosis, so I will be diagnosing this. How will I be diagnosing? So I will take the sample diagnosis, lab diagnosis. Lab diagnosis, what we will be taking? We will take the sample. So what is the sample? In males, you will take the urethral discharge, isn't it? You will take the urethral discharge. In females, you will take swab. In females, because females have a short genital tract, now we're taking the endocervical swab in females. Endocervical swab. Okay, don't go into the the high vaginal swab is not recommended, by the way. It's not suggested to do the high vaginal swab. Okay. Now tell me, sir, you also told us that there was another syndrome, that is DGI, disseminated gonococcal infection, isn't it? What is by the way DGI? I will tell you the symptoms first. Please write it here. This is after the ophthalmia neonatorum. Okay, write it below that. So DGI is disseminated gonococcal infection. So what is the condition? How will the patient come? What is the characteristics of this? Polyarthritis, multiple artery are involved, and sometimes, please write sometimes or rarely, endocarditis, and dermatitis. So rarely endocarditis and dermatitis. Okay. Who are at a risk of getting this? Menstruation and complement deficiency. I will be teaching you the complement deficiency in immunology, C5 to C9 deficiency, membrane attack complex. I will be teaching you. So these are the risk factors. If someone is having a complement deficiency, he will get the DGI with the infection of gonorrhea. Okay. Now for DIG, what will you be taking? In the DIG, what you will take? You will take the blood. And if joints are involved, I will take the synovial fluid, isn't it? It's common sense. Synovial fluid. Okay. So this is the sample you will be taking for the diagnosis. Okay. So then you will do what? You will do what? Gram staining. Since it's a gram negative, so you will be appreciating a gram negative diplococci on the gram staining. Okay. So culture, which culture will you use for this? Thayer-Martin and chocolate agar, isn't it? Same. Okay. They will ask you what is the most sensitive test for gonococcus. What is the most sensitive test for gonococcus? What you should write? Not. Okay, not. It is the most sensitive test. Not is the most sensitive test. By the way, what is not? Yes, you are not answering. Nucleic acid amplification test. Nucleic acid amplification test, biochemical test. Okay, checks the genetic material and all. So this is the test which is most sensitive for this gonococcus. So if someone asks you what is the ophthalmic neonatorium, you should add something. The purulent eye discharge plus can say acute conjunctivitis. Acute conjunctivitis. Acute conjunctivitis. Easy. Is there any doubt with this gonococcus? See, if you know the microbiology, how you can treat really nicely the patient, isn't it? Without any tension, you don't have to worry. You can directly, take the sample, send it to the lab. They will send you the report and accordingly give the treatment. So the problem is resolved. So let us tell you first. I want to, should I teach the difference between gonococcal urethritis and non-gonococcal? How will you differentiate that this is a gonococcal? Because urethritis can be caused by, many species, fungus, viruses, mycoplasma, chlamydia trachomatis, uroplasma urolyticum. What else I can say? Candida. So they can also cause. So how to then know, sir, it is caused by gonococcus? You should understand. So let me first give you a difference, or let me tell you first the resistance it has for the drugs. Okay, let me tell you the resistance it has for the drugs. So gonococcus has mutations. The resistance is happening by R plasmid. I have taught you. Okay. Now it has three resistances. What, sir? Penicillin, tetracycline, quinolones. These are all the drugs. Okay. Now this penicillin resistance can be two. It can be R plasmid mediated. It can be gene mutations. Because I wrote gene mutation or R plasmid. So which mutations are R plasmid? It has penicillinase producing Neisseria gonogo. Okay. Gonorrhea. Sorry. So PPNG is the R plasmid mediated. So which are through gene mutation? Gene mutation is by penicillin binding protein. So penicillin binding protein will be through the gene mutations. Okay. Tetracycline resistance is also R plasmid mediated. R plasmid mediated. That gene is known as T. That gene is known as T TET MG. TET MG. TET is tetracycline. So TET MG. So what it does, it will prevent ribosome. It will do a ribosomal dysfunction. Remember like this. Okay. Quinolone resistance through GRY4 plus. Okay. If you don't remember it, don't remember it. Just remember quinolones is through gene mutation. Okay. You can remember PAR-C gene like that. Okay. So these are the resistances we have to take care of. Now I want to first explain to you what is the difference between gonococcal urethritis and non-gonococcal urethritis. So let us do a small difference how to understand in the clinical practice that whether it is caused by gonococcus or some other infections. So non-gonococcal urethritis. Can we understand the short forms? Okay. So who is causing gonococcal urethritis? Neisseria gonorrhoeae. Neisseria gonorrhoeae. Who is causing non-gonococcal? They can be bacteria, they can be viruses, they can be fungi, they can be parasites. If I take bacteria, which bacteria can cause non-gonococcal urethritis? Chlamydia, Chlamydia trachomatis, Chlamydia trachomatis. So it is the, please remember a red pen like this, it is the most common cause of non-gonococcal urethritis. It is the most common cause of non-gonococcal urethritis. What about another word I can remember is I remember like this, MUCS. You can remember like this. Okay, so MUCS you can remember. M stands for Mycoplasma hominis. Let me write separately here. Don't write, oh, you will write it here. I don't trust in you people. Let me write here, Mycoplasma hominis. Mycoplasma hominis. Urea plasma. Urealyticum. Urea plasma urealyticum. Wherever you are not able to see the this spelling, please kindly tell me. Okay, so chlamydia trachomatis is the most common cause of non-gonococcal urethritis. Most common cause of non-gonococcal urethritis. But these are the other bacteria which are causing the non-gonococcal. Okay, so S is some cases. What, sir? What do you mean by some cases? Means some cases may be showing forms of the cocci, like we have L forms. Okay, so you can in short remember some cases also, or you can remember Chlamydia trachomatis, Mycoplasma hominis and Uroplasma urolyticum. That is enough for you to remember at this stage. Okay. Because sometimes the gonococcal infection has those forms of L forms, so you don't need to go into that detail. Just remember chlamydia, trachomatis, uroplasma, ureterica, mycoplasma, hominis is the non-gonococcal urethritis. These all can cause non-gonococcal urethritis. But if you think any time that he has a non-gonococcal urethritis, think that it should be chlamydia trachomatis. Chlamydia trachomatis. Easy. Now, which viruses can cause non-gonococcal urethritis? Herpes virus, and cytomegalovirus. Cytomegalovirus. Which fungus can cause? Candida albicans. Candida albicans. Which parasite can cause? Trichomonas vaginalis. Trichomonas vaginalis. Trichomonas vaginalis. Okay. Any doubt? Now let me tell you clinical difference. How I clinically will see. This is all about the microbiology part. Clinically, the patient of gonococcal urethritis will have the onset of infection within 48 hours. But the patient of non-gonococcal urethritis will come, he will have a greater than 1 week. Greater than 1 week. That is, onset is more longer. Okay. Now, if we talk about the urethra, so urethra in gonococcal urethritis will show me what? Can you tell me what is the name? Flow seed appearance. Flow seed? No, flow like seed, isn't it? Flow like seed. So it is a purulent. So I should write purulent. Okay. This can be mucus or this can be mucopurulent. This can be mucus or mucopurulent. Okay. Easy. What is the complication it can cause? Gonococcal urethritis, we said DGI, watery can, perineum. DGI, water can, perineum. Water can, perineum. Okay. Non-gonococcal urethritis, Reiter syndrome. What is Reiter syndrome? Yes. Anyone from the third year? What is the Reiter syndrome? Muca is the Reiter syndrome. What is muca? Muca means mucosal lesions. Mucosal lesions. U for urethritis. C for conjunctivitis. A for arthritis. So Reiter syndrome is the most common, is a complication of non-gonococcal urethritis. Okay, easy. How to diagnose gonococcal urethritis? Sir, you told us Thayer-Martin media. Thayer-Martin media. Sir, how to detect chlamydia? I'll tell you all the mediums name. Chlamydia, how to detect? McCoy or HeLa cell line. You can take HeLa cell lines. Okay, McCoy or HeLa cell lines. How to detect trichomonas? Sir, directly check the trophozoite of trichomonas. Trophozoites. Check the trophozoites. Babies, small infectious stages. Candida. What we'll be able to appreciate? Yeast cells in the discharge, isn't it? We'll see the discharge yeast cells. Sir, virus. What about the virus? How to detect the virus, whether it's a viral herpes or cytomegalovirus? Directly go for PCR. What we are doing today in the corona also, isn't it? So PCR. Go for PCR for chlamydia or HSV. Our diagnosis is done. Now treatment. How to treat gonococcal urethritis? I will be teaching the urethritis in detail right now, but let me tell you for others what you will give for chlamydia. Chlamydia, you will be given doxycycline. Doxycycline. Okay. You will be given doxycycline. Okay. For trichomonas, if you came to know that it was a trichomonas infection, go for metronidazole. Metronidazole. If we go for see the candida infection, clotrimazole. It is available as cream, vaginal cream, or even tabs. Okay, the tablets. So it's available as vaginal cream or the tablets. Okay. Now let me teach you the treatment. Understand you the treatment. Please write a separate. Take a separate and write the treatment of gonorrhea. If I could have told you the dosages also for these, but you are a first year student, so just remember first the drug. Okay, so treatment of gonorrhea. Treatment of gonorrhea, how will be treated? If it is an, if he has an uncomplicated infection, if he has an uncomplicated infection, if there is uncomplicated gonococcal infection, you will give, drug will be ceftriaxone. Ceftriaxone, how much? 250 mg, single dose. Other drugs which you can give other in the uncomplicated gonococcal infection is cefoxitin, cefotaxime, let me write like this, cefotaxime and ceftriaxone. Ceftriaxone. This is 2 grams. Okay. This is 500 milligrams and this is 500 milligrams. Okay, this is 2 gram IM single dose. This is a single dose. This is single dose. Single dose. Okay, single dose. So with cefotaxime you have to give these all choices. This from this you have to choose one. Plus you will be giving what? Azithromycin. Azithromycin how much? 1 gram. Chlamydia. Okay. This is the thing you will be giving the treatment. Okay. If I talk about if there is disseminated gonococcal infection, that is arthritis, synovitis, skin that lesions, so you will be giving what? Ceftriaxone IM, or you can give IV 2 days. Okay, and cefixime for 5 days. Cefixime for 5 days. If there is now this gonococcus can cause meningitis or gonococcal meningitis. If there is gonococcal meningitis, what you will be giving? Ceftriaxone, same drug. Ceftriaxone IV will be for 2 weeks. Ceftriaxone will be for 2 weeks. If there is gonococcal endocarditis, what you will be giving? Same ceftriaxone IV for 4 weeks. Okay. Now, if the patient is a neonate and he has ophthalmia neonatorum, directly give single dose. What? IV ceftriaxone. Now, in babies, we have to give according to the body weight. Then babies, when we give a drug, we have to give according to the body weight. So you have to give 25 to 50 mg per kg. Now, if you want to prevent, now that there is a chance of having. So what is the prophylaxis? Prophylaxis for ophthalmia neonatorum, that Creed's method, same 1% AgNO3, 1% AgNO3. Okay, and when the baby is getting delivered, at the time of delivery, give him what? Ointment. What? Erythromycin or tetracycline. Are we able to understand the treatment? Are you able to understand the treatment part? Guys, what's up? So I hope you have understood the treatment of gonococcus, how to differentiate gonococcal and non-gonococcal infections, and you know how to produce the bacteria also, the gonococci. And I hope you enjoyed the lecture, and thank you very much for your time and patience, and God bless you. See you in next topic. Subscribe to my videos so that you can get all the videos of medicine. Thank you.